This agent that you mentioned is now also called Talquetamab. So it's a GPRC5D targeting bispecific antibody. So it brings T cells to the myeloma cells. And at this ASH meeting, there was a preclinical presentation from our laboratory. The abstract was presented by Christy Verkleij, and she showed in her presentation that Talquetamab is very effective in killing myeloma cells from patients with a dose-dependent lysis of the tumor cells. And in this study, we were interested to identify determinants of response, because when you know the determinants of response, you may be able to increase the efficacy by making rational combination strategies. So what we found was that patients whose tumor cells had higher GPRC5D expression had a better response ex vivo in the lab to Talquetamab. We also found that a higher effector to target ratio was predictive of response in our ex vivo system. And we found as an important predictor of response that Tregs, regulatory T cells, so immune suppressor cells, were able to impair Talquetamab-induced myeloma cell lysis. So we found several predictors of response which may allow us to make more rational combinations. And one of these rational combinations is the combination with daratumumab, because daratumumab is able to eradicate CD38 positive Tregs, the most suppressive Treg subset. And indeed, in our lab, we find that daratumumab is able to boost the activity of Talquetamab. And we already published in Clinical Cancer Research a couple of months ago that daratumumab is also able to synergize with a BCMA, redirecting a BCMA-specific bispecific antibody. And we tested teclistamab, also a Janssen compound. Also, because the effector target ratio is predictive of response, it should be interesting to test whether prior induction therapy or reinduction therapy, whereby the tumor load is reduced, T cells increase, is able to further improve the clinical activity of Talquetamab. Interestingly, at this ASH meeting, there was also a clinical oral abstract on Talquetamab, which was presented by Dr. Chari, and he showed high efficacy of Talquetamab in patients that were extensively pretreated, even those with triple-class refractory disease. And Talquetamab had in this study a manageable toxicity profile. Most patients had some sort of CRS, cytokine release syndrome, in the first 1 or 2 infusions, but this was almost always grade 1 or grade 2, and this cytokine release syndrome could be adequately managed by either steroids or tocilizumab. And grade 3 was only seen in 1 or 2 patients. Infections were also relatively low in terms of frequency, which is important in such a heavily pretreated population, and some patients experienced skin reactions. But overall, I think Talquetamab is a new bispecific antibody which will be evaluated in earlier phases of multiple myeloma because of its high efficacy and favorable toxicity profile. So together with the BCMA bispecifics, GPRC5D targeting will be a new effective way of eradicating myeloma cells.